Welcome to the AOA News Inside Track podcast. Today's Inside Track podcast is part of the QIPS Insights series, which is brought to you by the Quality Improvement and Patient Safety Committee. We'll hear from leads of quality improvement and patient safety projects, exploring how they got started, what worked, and key lessons learned.
I'm Andrew Harris, Chair of the American Urological Association's Quality Improvement and Patient Safety Committee. I'm here today with Dr. Dave Friedlander, Assistant Professor of Urology at the University of North Carolina. We are very excited to talk with Dave today about his quality improvement work on pathways of care following emergency department discharge for renal colic. Dave, thanks so much for being with us today.
Thank you, Andrew, and thank you to the AUA for this tremendous opportunity to share some of the work that we're doing in UNC that I think is important and hopefully can be scaled across the country.
That sounds great, and we're excited to learn a little bit about this over this podcast. So Dave, tell us a little bit about the project. What was it about? What inspired you to take it on?
Yeah, absolutely. So I think as many quality improvement projects begin, the origin story is often in the form of these anecdotal observations in clinic. And for me, it was what seemed to be like no rhyme or reason as to when and why individuals that had presented to the emergency department with a diagnosis of renal colic were seeing me in clinic. So for example, I was seeing folks that had a staghorn 6-8 weeks after the initial presentation, which I'd argue is too long. These folks clearly needed an intervention. We probably should have seen them sooner. Conversely, I was seeing folks that had a 4-millimeter stone that had clearly passed. They were asymptomatic, and yet I still saw them in clinic a week later, really for a social visit as opposed to anything. And so clearly there's something that was amiss. And it led me to do a little bit of research, and I did come across some literature demonstrating pretty poor follow-up rates. In this case, looking at statewide data from Massachusetts. And that, interestingly enough, there were actually higher rates for follow-up with a primary care physician or family practitioner as opposed to urologist, and that these follow-up rates actually oftentimes varied according to one's insurance status, which I would argue is not a reason for that change. And so with that in mind, we went out trying to establish a standardized protocol by which risk was assigned to individuals after they'd been given a kidney stone diagnosis in the emergency department and were deemed suitable for discharge. And with that risk designation in mind, what the follow-up should look like for them. Another important piece of the intervention is that we provide standardized discharge instructions for patients in both English and Spanish, so as to explain to them what they should expect and how to get in touch with the appropriate follow-up individual.
I appreciate that. Thank you. That is phenomenal. And I think you touched on this a little bit, but why was it important to you all to address this issue? And it sounds like it's a little bit about what's right for the patient, also a little bit about how do you maintain the appropriate access and usage in your clinic. So if you could expand on that a little bit, I would appreciate hearing about this.
Yeah, absolutely. So I think one of the challenges that I've personally encountered, and I imagine is not unique to some of my experiences in the quality improvement patient safety realm, is that, yes, at the end of the day, it's always about trying to improve the quality of care delivered to patients, but oftentimes you also have to come to administrators or higher level individuals with the business case, right? Because ultimately any intervention you suggest will require some element of resource allocation. And so for me, it was as much about trying to make sure that we were appropriately allocating resources as it was also improving rates of follow-up. So what we found, for example, is that only 10% of individuals being discharged from the emergency department were having a follow-up within a UNC affiliated facility within that recommended 6-week period. The literature suggests about 15% of folks with a renal colic diagnosis will ultimately require surgery. So at a low level, there are probably 5% of individuals that are seeking care elsewhere and having that high revenue, high RVU surgery performed within their healthcare system. Not to mention, fragmented care, disjointed care has a deleterious effect on patients' outcomes and experience.
Yeah, I appreciate those thoughts. Sounds like you all did a really nice job of understanding current state. You already, commented on a few different percentages about how many people follow up and a little bit about the patient following up, no matter how big their issue was, at kind of a similar interval, which may not be inappropriate. So you did a great job understanding you had a problem. I think so many times in quality improvement, people think they have a problem and they go start doing things. They're not sure they have a problem. So I appreciate that very much. So once you all understood that you had an issue, how did you start to approach the potential change? You mentioned the standardized discharge instructions a little bit earlier, but can you walk us a little bit through, how you started to approach this issue?
Yeah, absolutely. So I think what was nice about this particular intervention is that it was actually part of a larger program offered here at UNC, referred to as the Institute for Healthcare Quality Improvement Scholars Program. So it borrows quite a bit from the IHI Open School with regards to curriculum, but it also teams you up with a UNC provider who has a quality improvement patient safety background, and they provide mentorship as well as connect you with staff that can provide some practical suggestions and approaches to conducting this type of work. And so in our case, and this is going to be a plug for the quality improvement patient safety recently released document describing how to conduct quality improvement research and some of the resources that are out there to think about the formalized approach and framework by which you solve some of these problems. But in our case, it was really starting from the beginning using things like a driver diagram, a fishbone diagram, getting in touch with stakeholders to identify where some of the gaps in care were and what we could start looking at as a process outcome and balancing measures.
So once you started to understand, so more of an understanding of current state, right? Like data, you knew you had a problem, but then you started dissecting a little bit contributors or flows in the process that may be exacerbating the issue. So once you had that information, then what'd you do?
So in essence, at that point, we tried based on stakeholder field or feedback, we recognized that there was part of the problem was that ultimately folks didn't know what to do with these individuals. That they were clearly, for example, that 4 millimeter stone, sometimes urology was being consulted, whereas for the staghorn stone, folks were just being given a phone number and instructed to follow up and call urology. And so one thing we discovered, a clear barrier, was actually putting that ambulatory referral order in place. And so we sort of stepwise started thinking about some of these interventions that we thought would improve patient engagement, as well as break down some of the barriers to achieving our end goal, which was ultimately establishing ambulatory post-ED discharge follow-up for patients.
Yeah, that's fantastic. I also appreciate you commenting on the AUA project guide. Thank you for doing that. Actually, it's on the AUA website. So as you started to implement pathways to get these orders put in, how were you tracking whether or not you're being successful?
Yeah, and what's funny is as part of this IHQI Scholars Program, that was one of the first pieces that was addressed was, okay, you have this great idea, you have these interesting interventions, how are we going to track progress? And so early in the process, we got connected with enterprise data analytics groups, and we're able to start getting automatic data feeds on certain, whether they were measures or even patient features that we wanted to capture on a monthly basis, and that we did just that. So in our case, we went ahead and used diagnosis codes consistent with the renal colic diagnosis that were picked up on during emergency department encounters at two of our main facilities, with the goal of eventually spreading that data acquisition to the entire health system.
Learning more about quality improvement, it seems the more you can automate data collection as opposed to manual data collection, the easier it is for a process to be successful as long as your data fidelity is good. So that's fantastic. Did you notice anything about outcomes or patterns that just kind of stood out to you as you started to collect the data?
Yeah, so I mean, I think first and foremost, the most striking piece was the really low rate at which ambulatory referral orders were being placed, or at least that we perceived them to be being placed. And what we discovered, and again, this speaks to the importance of doing through the early work, the stakeholder engagement, through talking to our schedulers, we found that ambulatory orders were being placed in the wrong work queue. So they would be sent to a regional work queue that our department had no insight into. And so in order for these referrals to be recognized by our department, they literally had to be moved from one work queue to the other. And until that conversation, I don't think anyone recognized that or realized that. So that was really striking. I think the other piece was just realizing how long it takes folks to get into our clinic. And and thankfully this intervention has dramatically improved that. But I now have a keen appreciation for patients coming in and saying, well, it's impossible to get in to see you all, because it's tough.
I appreciate those comments. I think it's always interesting when you start to examine these processes, how you mentioned that, well, nobody knew that was going in the other work queue. Like something like that can totally derail the entire process because there's an assumption that somebody's dealing with that work queue. But that's the wrong assumption, right? Until you start to look at it. I always think that's interesting. People are doing their job on the front end, they think, putting the work order in, but people aren't receiving on the back end. And people think we're doing the right thing, but then you take a look at it and you're like, wait a minute, which actually has very little to do with people trying to do the right thing, right? It's just from the technological where it was going. I think that is always so interesting and a huge win for you all that you found that. So I appreciate those thoughts very much. So were you initially successful with your first shot, or did you guys have to do some modification to that standardized pathway?
Yeah, absolutely. It was definitely, or I could say it was iterative in nature. Unfortunately, no, it was not this smashing success that I, of course, thought it would be initially. And part of that was, again, the way we picked up on that was doing the, Gemba walks through the traditional QI work, getting on the ground, on the front lines, and understanding what our vision of this intervention looked like compared to its reality on the front lines. And so after conversations, understanding ways to spread knowledge about the intervention and some of the resources that are inherent in it, we began to get a little bit more traction. Although what's interesting is, so somewhat fortuitously, the health system was investing heavily in these automated care pathways across a variety of not just conditions, but care settings. And so our project was thankfully picked up as one of the initial emergency department pathways to be integrated into this back-end software known as Agile MD, which importantly also integrates into our electronic health record system, which is, in this case, Epic. There are a variety of these software capabilities out there. This just happens to be the one that UNC partnered with. And so that our intervention ultimately got selected and now is live within the health system as a pathway. But despite what seemed like a tremendous victory and would ultimately lead to better traction and utilization, we found that utilization's actually gone down since that go live. And that led to a variety of conversations and talks, and needless to say, one's best plans. I'm butchering the expression here, but needless to say, it has not gone as anticipated, and we continue to iterate to improve utilization.
If you were to describe the impact, and you spoke about it a little bit, but if you want to put it together in a few sentences, the impact the project's had so far.
Yeah, absolutely. Well, I think first and foremost, it is improving ambulatory follow-up rates for patients. So we went from, and granted, we are using that ambulatory referral order as a proxy for this, but we went from 10% pre-intervention to well over 40% post-intervention, which I would argue is still not adequate, but a market improvement. Equally as significant, not only are a greater number of folks getting in to see us, but they're coming in to see us in a more timely manner. So our average time from ambulatory order placement to follow-up was around 60 days pre-intervention, now down to 40 days post-intervention. So, I would argue that's had a dramatic impact. It's also, and this is sort of an intangible result, but it's led to a number of conversations with stakeholders in the emergency department, even at the health system level, whether it's informaticists or decision makers. And I think that set us up nicely to not only improve upon this project, but also to have urologists making a lot of these important decisions as it pertains to trying to automate care or standardize care.
That's fantastic. Really sounds, that it's been great for patients. It's been great, for the clinical applicability of the urologist, and then also just a great example of how can we grow and spread and allow you all to be involved in those decisions. That's fantastic. As projects go on, sometimes keeping them on track can be a challenge, right? So you can talk a little bit about, as you all are moving forward and maybe helping the ER out or the emergency department out with other things, how do you keep the results sustained, or how do you continue those iterative PDSA cycles over time so it doesn't regress back to the 10% follow-up rate you mentioned earlier?
Yeah, no, and I think that is the secret sauce behind a successful quality improvement intervention, because the reality is, if you have a champion, but that champion, becomes bogged down in other obligations or, goes somewhere else, the reality is you can lose a lot of momentum. And so from my perspective, it's always been about data acquisition to monitor how we're doing. And then also increasingly, I've become interested in informatics, machine learning, AI, to automate a lot of these processes. And so that's actually the next iteration where we discovered that, calculating these risk categories, for example, is actually kind of nuanced. There are a lot of parameters or features that go into it, and it ultimately relies on the frontline providers to collect that information in real time and then make an accurate assessment. And so we recognize that as a potential barrier to sustainment. And as a result, we're working with our informatics team here to automate that risk calculation and actually lead to a trigger that would automate a best practice advisory or out practice advisory so that the provider doesn't even have the opportunity to forget about this pathway. It's automatically populated. So I think this is a nice example of where, the promise of AI is actually delivering. And I'm really excited about this.
That's fantastic. We'll be excited to hear how this continues to progress in the future, not only with patients with renal colic, but also across other issues as well, and across the nation possibly of renal colic, if people can pick this up and kind of move it forward. So really appreciate you taking the time to share this with us. It's been really enlightening. Dave, thank you so much for being with us today.
Yeah, thank you. My pleasure. I really appreciate the opportunity to chat with you and would welcome engagement from the larger community. If anyone has questions or thoughts about how to do similar work, I am more than happy to share my thoughts.
That sounds fantastic. We appreciate this very much. Thank you for listening to this podcast, and be on the lookout for new episodes from our QIPS Insight podcast series.
This has been QIPS Insights, an AUA News Inside Tract podcast brought to you by the Quality Improvement and Patient Safety Committee. For more information about AUA's quality improvement and patient safety efforts, visit auanet.org/quality.